Good morning. Thank you so much for joining us and for lending your expertise to HPIO's 2019 Health Value Dashboard. I'm Reem Ali with HPIO. I also have with me in the room Amy Bush-Stevens and Zach Reet, who you will be hearing from through this morning as well. We are very excited to share that we are in the final stretch of compiling and laying out the data for the 2019 Health Value Dashboard and wanted to touch base with all of you as we finalize our layout. The agenda for our meeting is here on your screen. We'll have several opportunities for group discussion throughout the morning. As a reminder, the agenda and pre-read meeting materials are posted on the Health Measurement Advisory Group page under Meeting 2. We will also post a recording of today's webinar after the meeting. We've provided several documents for you to review and have also uploaded these documents for you in the webinar. They're under handouts on your screen, so you should see them there. And these include the Health Value Dashboard, main profile metric list, the equity metric list for the equity section of the dashboard, and then draft laid out sections for the domain profiles and equity profile in the dashboard. And we'll hopefully be getting some of your feedback on those later this morning. If you have any questions about meeting logistics for today, please feel free to reach out to Alana Clark-Kirk. Her information is on the screen. We would like this to be an interactive webinar and encourage you to type your questions into the chat box, or you can raise your hand if you would like to speak using the hand icon. We will pause for both questions and discussions throughout the meeting. For you to participate, though, it will be important that you log into the meeting via your computer, call into the meeting using your phone if you have not already done so. You'll be prompted to enter in your audio PIN so that you are able to speak. And you can find your audio PIN at the top of your screen. You see here objectives for today's meeting, which will follow closely with the agenda. We really would love to get your feedback on considerations for which greatest health challenges and evidence-based strategies to emphasize in the dashboard, and then opportunities to improve messaging and dissemination for state policymakers. And we'll get into this more. As a reminder, our first Health Value Dashboard was released at the end of 2014, and we released the second edition of the dashboard at the beginning of March of 2017. Our organization has made a long-term commitment to update the dashboard every 2 years. With the help of this advisory group, we are in the midst of developing the third edition of the dashboard, which will be released in early April. This is the timeline for the 2019 dashboard. Many of you were with us back in the spring of 2018 when we were reviewing and finalizing metrics for the 2019 dashboard. Throughout 2018, we were busy with data compilation and analysis and are in the layout and messaging phase of the 2019 dashboard now. We'll have a series of dashboard forums for release of the dashboard in April. There are 59 members of the Health Measurement Advisory Group, and you can see here the various work groups that have helped inform development of the 2019 dashboard. Over the past year and a half, HPIO has also been convening a separate equity advisory group that really emerged from our dashboard work to inform our equity-related research and products. We have taken the opportunity today to invite members of our equity advisory group and provide them with an update on the dashboard and get their feedback, and particularly on the equity component of the dashboard. We'd like to start off this meeting with just a few poll questions. We know that many of you are committed HPIO stakeholders. So a question for you, which advisory group are you with? Who do we have on the call today? The Health Measurement Advisory Group, are you a Health Measurement Advisory Group member? A member of our Equity Advisory Group? Has HPIO completely taken over your life and you're on both? Do you know that HPIO has taken over your life but are unsure about which group you're on? We'll pause for just a little bit to give you all a chance to respond. This might be a test for you. We know that many of you participate on a number of our advisory groups and very much appreciate that. So let's see who we have with us on the call today. All right, well, it looks like we have taken over everybody's lives. So sorry for all of the emails that have been going back and forth, but it looks like a little over 40% are on both groups, and most of you know what group you're on. I'm really impressed. That is extremely impressive. So we really appreciate you joining us on this journey, which leads us to our second poll question. How many of you have been on this dashboard journey with us before, participating on a dashboard work group or the broader health measurement advisory group for our previous dashboards? Is this your first time ever working on a dashboard, or were you able to work with us on the 2017 dashboard, or is this your third time around? So you've been in it for the long haul. Give you a little bit of time to respond. I'm so curious. All right, let's share those results. Wow, again, very impressive. So it's a kind of a second time around is taking the lead, and then some of you have been in it with us for the long stretch. We so appreciate that and are glad that you haven't gotten tired of us over this period of time. And for our newbies, we really appreciate you joining us this time around and hope that you can also help advise us on the fourth edition of the dashboard, which I don't even want to think about right now. Now, for those of you who are new to our dashboard journey, or are maybe members of our equity advisory group, I just want to give you a little bit more background on the dashboard. The dashboard is a tool we developed with input from many of you and other stakeholders to track Ohio's progress towards health value. This, of course, is the conceptual framework for the dashboard, in which we define health value as a composite measure of improved population health and sustainable healthcare spending. We also acknowledge that there are many systems and environments that impact our overall health and that can impact health value, including our healthcare system, public health and prevention, access, and our social, economic, and physical environments. Through a set of more than 100 measures, the dashboard tracks Ohio's performance across all 7 of these domains, as well as across equity. We do align with other national dashboards and scorecards that you might be more familiar with. However, the Health Value Dashboard has a stronger emphasis on healthcare spending, providing a comprehensive overview of the various determinants that impact our health, a focus on health value, so that composite measure, and then a focus on health equity. The dashboard is displayed in a concise, at-a-glance format for a policymaker audience. The primary audience for the dashboard are our state policymakers. We believe that collecting this publicly available data in one place is a very important starting place for us to build a framework for accountability and understanding our performance on health, spending, the drivers of health, and equity in Ohio. The dashboard looks at Ohio's performance relative to other states and tracks change over time, and also identifies Ohio's greatest health disparities and inequities, which was a new component of the dashboard in 2017 and one that we are building on for 2019. This is our second dashboard, partnering with researchers at Ohio University for compilation of the data. I am sure, since many of you are really lifers with HPIO, that you've seen this slide many times before, but in 2017, we did rank very poorly on health value. We were 46th out of 50 states in the District of Columbia, 43rd on population health, and 31 on healthcare spending. And we are quite anxious to see what our value ranking is going to look like for 2019. We don't have that information yet, but expect that soon. All right, and with that, I'm going to turn it over to Zach Reet from our team, who will be giving you some updates on the metrics that we included in the 2019 dashboard.
Thank you, Reem. And as Reem has already reviewed, we worked closely with the Health Measurement Advisory Group members and work groups that formed around each one of the domains that's included in the profile to update the list of metrics that would be included in the 2019 Health Value Dashboard. As we went through that process, we focused on trying to preserve as much consistency as we can in the metrics that are included in the dashboard. One objective of the dashboard is to be a tool to track Ohio's progress, and an important part of doing that is making sure that we have consistency in the measures that are included. So what I'm going to do first is quickly review some of the metrics that are new to the 2019 dashboard. That is, they weren't included in the 2017 or 2014 editions. And then we'll talk about a few revisions to metrics that have happened since we last communicated with you back in the late spring, early summer. So in the population health domain, we've added a metric about adult obesity, which is replacing the youth obesity metric from the dashboard. This is because data on youth obesity doesn't work so well in the context of the dashboard. The Ohio Medicaid assessment data cannot be ranked. The data from the National Survey of Children's Health cannot be trended because of a change in the methodology for the survey. And then data from the Youth Risk Behavior Surveillance Survey is too old for the state of Ohio to be included. In healthcare spending, there are 4 new metrics that come from a new analysis of the National Health Expenditure data that was published by CMS, or the Centers for Medicare and Medicaid Services, in 2017. This is an analysis that will be updated every 5 years, but was published just after the publication of the last dashboard. The first metric will look at total healthcare spending per capita, and that's for all privately and publicly funded personal healthcare services and products. And then the other 3 metrics from the analysis will look at per capita spending by service area or provider type. And the 3 areas that we chose to look at in this dashboard were hospital care spending, nursing home spending, and then prescription and medical non-durable spending, which looks at retail sales of those products. 2 new metrics in the healthcare system domain come from an analysis of enrollees in employer-sponsored insurance. These metrics were included in the Commonwealth Fund's scorecard on state health system performance. We've heard from advisory group members in the past that the dashboard should include information about private health insurance and outcomes for enrollees. And so this first metric looks at potentially avoidable emergency department visits for employer-sponsored enrollees. This replaces the metric that looked at avoidable ED visits for Medicare beneficiaries. And then the 30-day hospital admissions for employer-sponsored enrollees replaces a metric that looked at all payer, all cause readmissions, but was from the Ohio Hospital Association, and so therefore didn't have other state data to rank or trend. The final new metric in healthcare system is back pain recommended treatment, which is a replacement for the stroke care metric that had been included in previous dashboards. That metric was removed from the hospital compare data set, and in consultation with the work group, we added this new outpatient imaging efficiency metric from that data set. In public health and prevention, motor vehicle crash deaths was selected to replace safe sleep as an injury metric. That metric came from the Pregnancy Risk Assessment Monitoring Survey, PRAMS, and we'd need to use OPOS data for that. We also have several other infant mortality related metrics in the dashboard, and motor vehicle crash deaths is an issue that affects a large number of people. There's also good alignment in this metric with county health rankings and America's health rankings as well. In social and economic environment, we've added a disconnected youth measure, which looks at youth ages 16 to 24 who are not working or in school. This replaces the social capital and cohesion metric, which is no longer available to trend because of changes in the underlying data source. And again, there's good alignment here with county health rankings and kids count. Long commute driving alone was added to the physical environment domain as a replacement for bike and pedestrian infrastructure funding. Again, this is a metric that aligns with CHR. The next metric, neighborhood resources, comes from the National Survey of Children's Health, which refers to the metric as the presence of neighborhood amenities. So looking at the availability of public places and services like libraries and parks in communities. It's also notable that fluoridated water had to be removed from the physical environment domain because there wasn't updated data available for that metric. So now I'll quickly go through some revisions since late spring, early summer, when we last communicated these metric updates to you. Several of these revisions are changes in sources where we have gone from an organization that compiles data from a primary source directly to the primary source. There's a lot of different reasons that that would happen, but I won't spend a lot of time talking about those. I will remind you, though, that on the updated metric list that was sent out with the meeting materials, we have gone over each of these changes. So these first two changes in population health fall into that quick change category. Suicide deaths, we've moved from a compiler to the to the National Center for Health Statistics, And then for life expectancy, we've moved around from several sources, but we've landed back at Measure of America. In healthcare spending, we've changed sources to the Kaiser Family Foundation for several of the Medicaid spending metrics. This is because Kaiser had numbers available for more states than MACPAC did. And then for local public health agency spending per capita and a metric we'll see later in public health and prevention, local public health workforce, we've changed the source in that we're using raw data from the National Association of City and County Health Officials, whereas before we had used metrics reported in their publications. So in the case of this metric, and again, the local public health workforce metric, we're actually working with the same underlying data source, just doing analysis of the raw data. In access to care, youth with depression who did not receive mental health services, we simply had to compile the data from a set of 51 reports. It wasn't easily available. And then for the uninsured non-elderly metric, this is a new metric for the dashboard. It replaces uninsured children and uninsured adults. This was a change that was made because the American Community Survey changed the age brackets that they report uninsurance by. Most importantly, adding people who are 18 to their uninsured children reports. So we've combined those uninsured children and uninsured adults into a single metric. In healthcare systems, we've made a change to the healthcare associated infections metric to better align with the way that the Centers for Disease Control and Prevention is tracking and reporting the state's performance on healthcare associated infections. In consultation with the work group, we selected this central line associated bloodstream infections from a list of 7 different healthcare associated infections that are tracked and reported by the CDC. Nursing home pressure ulcers was a simple source change where we moved from the Commonwealth Fund to the Nursing Home Compare data set, again from a compiler to a direct source. The same is true with child immunizations. For environmental and occupational health and health security surveillance, these are 2 new metrics that replace the foodborne illness metric, which was removed from this domain. The foodborne illness monitoring metric was included as a metric in the health security surveillance domain of the National Health Security Preparedness Index. And in consultation with the our consultant, OU, as well as the underlying data source, we determined that it wasn't good to continue using the foodborne illness monitoring metric to compare to other states and track progress over time. So we went with these 2 subdomains from the National Health Security Preparedness Index. I've already talked about the change related to local public health workforce, which is a change in source from the nature reports to raw data. For social and economic environment, income inequality, we switched from a source that reports the Gini coefficient to a source that reports a simple ratio between low-income earners and high-income earners in a state. So this is a change that allows for easier interpretation of the metric. And then for disconnected youth, again, we've gone from a compiler, several organizations have compiled this metric, to the primary source in order to have the most up-to-date data. In physical environment, a substantive change was moving from a metric that looked at children exposed to secondhand smoke from the National Survey of Children's Health to a metric that looks at children who live in a household where an individual uses tobacco. And we've renamed that metric to child in a household with a smoker. The reason for the change is that with the new methodology at the National Survey of Children's Health, a lot of states did not have reliable estimates for the number of or percent of children exposed to secondhand smoke. Lead poisoning was a change from a compiler to the direct source, which is Ohio Department of Health. The same is true for severe housing problems. And then just a quick note that the safe drinking water metrics and the safe routes to school program metric were removed because of a lack of updated data and also some concerns about the reliability or the consistency of the underlying data that goes into calculating those metrics. So with that, I'll turn it back over to Reem, who is going to talk a little bit more about some healthcare spending.
Thanks, Zach. I'm just going to pause here for a second and see if anybody had any questions for Zach on the metric updates. We'd like to get your feedback on Medicaid benefit spending per enrollee, or this is a average amount Medicaid spends per full year equivalent for all Medicaid enrollees by enrollee. So this is across all categories: children, adults, aged, and those with a disability. Previously, in the past 2 editions of the dashboard, we have not ranked Medicaid spending as a part of our healthcare spending domain. And that has primarily been because of differences in the Medicaid programs across states, that there was some hesitation in ranking the measure because it was not an apples to apple comparison. However, as we've been presenting this data, particularly to state policymakers, the issue of Medicaid rank and how we perform on Medicaid spending as compared to other states has always risen to the top of the conversation. State policymakers often think that we are including that measure in the domain profile, or may make assumptions that we are doing poorly on Medicaid spending when we are actually, in fact, kind of the middle of the pack. It's one of the better measures that we have in healthcare spending as compared to other states. So we wanted to get your thoughts on ranking this metric. This will help inform us in our decision to whether or not we do rank this metric in the 2019 Health Value Dashboard. It can be useful in first kind of really kind of challenging the assumptions that state policymakers have when it comes to the Medicaid program, and also by ranking, it can give us a little bit more insight on how Ohio performs relative to other states and whether we should maybe look at other state Medicaid programs to see how they may differ in structure and function to our state Medicaid program. So it does give us some ability to have a little bit more insight and context on Medicaid spending when we do rank it. Of course, the concern being that it is not an apples to apples comparison across states. So I want to just open up the line to you all. You can use your hand icon to raise your hand, and we will unmute you so that you can ask your question. I also will pull up the chat box. So let me see here what questions we have, and please do raise your hand if you'd like to make a comment. I do see several hands raised, so I'm going to go to the chat box first. Please keep your hands raised, and we'll get to you as well. Just really quickly, so this is an aside from the Medicaid discussion, Carla Hicks wanted to know why the stroke care metric was dropped. And so I'm going to just turn it back over to Zach to answer that quickly.
Yeah, that was a change that was made back in the late spring, summer. Updated data is no longer available from that hospital compare data set, and couldn't find a real good replacement that would continue to track this particular issue. And so the work group looked at several potential replacements and eventually voted through email and selected the back pain recommended treatment measure.
Thanks, Zach. And I see lots of questions around the Medicaid spending measure. So Marie Curry is asking for ranking Medicaid benefit spending. Do we compare to all states, or is there a subset for states that have expanded Medicaid? I don't think this is a valuable measure without an adjustment for case mix. If we have a sicker Medicaid population, we will have an appropriately higher spend. And I think that comment was from Dina Chisholm. David Norris is asking how are better and worse defined in the context of Medicaid spending. So we would consider better lower spending on Medicaid, and worse would be higher spending per enrollee on Medicaid. To the question of how do we compare, are we comparing to all states or a subset of states? We're originally exploring comparing to all states and ranking Ohio's performance relative to all 50 states. And this would be a per enrollee measure, so it's total Medicaid spending or average Medicaid spending per enrollee. So getting at that kind of per person. Is everyone, policymakers, but also us, clear on what makes for good or high-ranked Medicaid spending? Is it across the board better to spend less, what if there is a positive reason a state is spending more? And this is from Tasleem. I think that's a really good question. It does give us a starting place for a conversation that we couldn't have if we didn't rank the data. So I don't think that there is a clear-cut answer to that, but it does give us a starting place to explore the states that maybe have lower spending than Ohio. How does their Medicaid program differ from ours? And those that are higher, how does their Medicaid program differ from ours? And how does that impact outcomes? Let's see, this is from, oh, so we're getting so many. If Medicaid spending frequently comes up in conversations with policymakers, then it should definitely be included with whatever caveats they'll listen to. Thanks, Larry. That's from Larry Hollingshead. Linda says, I like the measure, but think it needs to be separated as per your highlighted lines. Could consider adding aged and blind together and consider if we can differentiating nursing facility versus non-institutional spending. We will have metrics around the per enrollee spending for children, adults, aged, and enrollees with a disability in the Medicaid program. Unfortunately, that data is older. I believe that's 2014 data, and there are some issues in the consistency of that data over time, so we wouldn't be able to rank or trend that data. The one metric that we are considering ranking is more recently available data, so it's fiscal year 2017, and if we were to continue with this for future editions of the dashboard, we would likely be able to trend this measure over time as well. I think health outcomes for Medicaid enrollees over time might be a more value in determining value. That's from Terry Allen. And then spending on social services such as housing, access to healthy food, job training should be displayed next to Medicaid spending in order to get true healthcare spending, since social determinants make up such a significant portion of health. And I think that that's a pretty valuable point. We will have more of a narrative that accompanies the healthcare spending population domain. So if we do end up ranking the Medicaid metric, we will also have the opportunity to provide, and Amy Bush-Stevens from our team will talk a little bit more about how we're updating the domain profiles, but we'll also have an opportunity to provide a little bit more context around that measure, and then also how we're doing on spending for public health. And there's clearly this imbalance of how much we spend for public health services versus healthcare spending, and that is something that we will want to highlight in the dashboard. I want to turn it over to those that have been waiting on the line with their hands up. So first is Kathy Costello. Kathy?
Thank you. I just wanted to make the point, I think this is a really important area to discuss. What we saw 2 years ago in the last budget cycle is that legislators did not understand the change to an alternative payment model by Medicaid to the CPC program. And so they had originally cut it out of the budget, and then it was only put back in because of big push to make sure that it was kept in to reward primary care. And I think it's critical that when you rank this, and I think several people have made this point, that this is a narrative where you have to have your dollars on one side and the explanation on the other. And I think that you're with the CPC program, because this is the third year of it now, you're going to start having data from 2017 that can be put forth, but not everything, because of the model itself had problems collecting data for some of the vital signs, for blood pressure and stuff like that. So you're going to have to work with Medicaid to make sure that you have a good narrative around that. But I just would encourage you so much, because of the fact that the policymakers use your data a lot of times, that we make sure it's very clear what Medicaid is doing to support the population, even if it means decreased or increased cost, whatever the figure looks like.
Thanks, Kathy. I think that those are points that we should definitely take into consideration, particularly providing more context and narrative. If we do decide to rank, it's important that we have a little bit more context and narrative around what Medicaid spending means, and maybe just even as a starting place for discussion. I'm going to move to Denisha Porter. She also has her hand raised. Denisha, I think you need to enter your audio pin in, which should be at the top of your screen. So you would have needed to log into your computer, call via phone, and then enter your audio pin in order for us to be able to hear you. We got it. All right. Denisha, you have the floor.
Yeah, so actually that was in a response to me not being able to hear the speaker. But
Okay.
now
All
so
right.
that up.
Okay, great. Thank you. Okay, any other questions or comments? I don't see any other hands raised or any other comments in the chat box. This is a metric where we do know where Ohio ranks. So we have the data, and Ohio ranks in the second quartile. So we actually do relatively well if we're thinking about lower Medicaid spend as compared to other states. Of course, many of you brought up a number of points that we need to do. That can't be the message to state policymakers, is just bringing down the spending. What if some states have higher healthcare spending, but they're doing better things for their Medicaid enrollees? So that will all need to be nuanced in the narrative. It does, however, provide a little bit more context for policymakers who may just automatically assume that Ohio does poorly on Medicaid spending, and so it will give them a little bit. It will give them a little bit more information. So we also understand the point about case mix, and we'll take that into consideration in making our final determination. Any other thoughts? Any other thoughts on this, or any other comments in the chat box? We know that this is an extremely sensitive topic and issue, and we really just wanted to get your feedback and see what reactions you might have. Certainly, if we go the route of ranking, we understand that the narrative is the most important component or context that we can provide. If we go the route of not ranking, I think it's still, it seems from your comments, still important to provide some more narrative around Ohio's Medicaid spend. And so we'll kind of weigh the considerations. I do want to give the floor to Linda. She has her hand up. Linda, you do not have your audio pin in, so if you can please call via phone and enter in your audio pin. I think we got it. Linda? No, we don't have it yet. So Linda. Okay, Linda, you made a comment. It says, if you divide the date out, it will age adjust. I don't know that I fully understand what you mean by that comment, so I will follow up with you, but you put your audio pin in now, so you can explain. All right, Linda, you have the floor.
Well, what it means is if you divide the data the way you've got it highlighted, per enrollee child, adult, disability, and aged, they're adjusted, that age adjusted in terms of what it means it should give them a feel for where the money is going.
Okay.
Or the way it comes to the managed care plans and to CPC is already risk adjusted in the state of Ohio. So just two things to keep in mind that may help with that.
Got it. Okay. That's really helpful context. And we might do some more follow-up with you, Linda, on that. Terry, one last comment. There's some general concern about unintended consequences related to how the metric could be used. Totally understand that, Terry, and that's why we wanted to get your feedback first and think through this idea or notion of ranking. It's something that I think state policymakers just automatically want this metric to be ranked. But of course, what story does that tell, and how can it be used for good or for evil? We're not sure, and we want to make sure that we're really conscious about how we're displaying that data. So really appreciate all of your feedback on this. Just want to make sure that there's no more hands up. It doesn't look like it. And we may touch base with some of you that have had comments just to get a little bit more context and clarification. Really appreciate the discussion on this, though. Thank you. All right, and with that, I am going to hand it over to Amy Bush-Stevens to talk about some of our layout updates in the dashboard.
Good morning, everyone. This has been a great conversation so far, and it's wonderful to see that we have so many people on the call today who have been involved in the dashboard, at least for 2 rounds, and many of you since the very beginning, since way back in 2014, probably 2013 is when we actually started this work. So thank you so much for sticking with us and providing your insights and perspectives with us. I'm going to talk about some of the updates to the layout of the dashboard. We are always working to improve the dashboard and how it looks and how it conveys information. And so we're going to highlight a few of the ways that we're doing that this time around. Last year, we asked you to fill out, at least the members of the Health Measurement Advisory Group, an online survey to provide feedback on what we can do to improve the dashboard. About 40 of you filled out that survey. And as you may recall, the biggest suggestion was to include a concise set of evidence-based strategies and to keep things simple. So we were warned here to not boil the ocean. That is always a challenge for us. So we are keeping these 3 things in mind as we make revisions to the dashboard to simplify it to the extent possible. Of course, we just had a great conversation about how we need to provide narrative and nuance and context, but then balancing that with the need to be concise and to simplify the message, to tell a clearer story and really connect the data more directly to strategies. So I'm going to share a few examples of how we're doing that. First, we'll look at the domain profiles, which will remain mostly the same, but are slightly streamlined. And you did have a few examples of this in the packet, in the PDF. And the first thing that we're doing here is removing the most improved states column. So the image on the left is from the 2017 dashboard. The image on the right is from the preliminary draft provisional do not distribute 2019 dashboard domain profile. So just slightly simplified by removing that column, which we had feedback was not super useful. And then we've also added this ranking slider across the top for each domain. So you can quickly at a glance see where the domain overall ranks compared to other states. And as Reem mentioned, we do plan to add more narrative around a few key aspects of the population health and the healthcare spending domains. So those are the 2 domains that feed into the overall health value rank. So we want to make sure that our readers of the dashboard have a very clear sense of what we mean, what this data is telling us in these sections. And so for population health, for example, we might do a page digging more deeply into tobacco. That's just a potential example. And then for healthcare spending, obviously, we would have additional information that would address many of the concerns that were just raised in the discussion we had about Medicaid spending. Now thinking about the concise set of evidence-based strategies to include in the dashboard, this image is from a page of the 2017 dashboard where we highlighted 3 general approaches and gave some examples of specific strategies. This time, we want to make this more prominent in the dashboard and really put a sharper focus on some specific actionable policies and programs related to some of the greatest health challenges. And last time we did these lollipop graphs. We had 4 lollipop graphics that look at trend for Ohio and neighboring states. And some people really loved the lollipop graphics, including Amy Rowling McGee here. Others felt like it was a lot to digest. So we will likely be including some of these in spin-off closer look policy briefs to deep dive on some specific topics. And now I'm going to turn it back over to Reem to talk about changes to the equity profiles.
Thank you, Amy. As I mentioned earlier, the first time we introduced the equity profiles into the dashboard was in 2017, and it was received very positively. We certainly want to build upon and improve the effectiveness of the profiles, and we'd like some more input on you on whether or not we're moving in the right direction with this for 2019. In the 2017 dashboard, we looked at both health disparities and inequities across a set of 29 metrics and examined those metrics by race, ethnicity, income level, education level, and disability status. Within those population groups, we used disparity ratios to calculate the magnitude of difference between the group with the best outcomes and the group with the worst outcomes to identify some of Ohio's greatest gaps in outcomes within those groups. And the thresholds for what constituted a large, medium, or little to no disparity were adopted from Healthy People 2020. This is what the domain profile looked like, or the equity profile looked like. So you'll see here we have it by the dashboard domain. We list out each population group, the value, and the data values for each. And where we can, we provide data on the estimated impact if the disparity or the gap in outcome was eliminated. And this is just to orient you to how we had approached the layout and display of the dashboard in 2017. We heard from many of you and other stakeholders that the data in the equity profiles was very important to include and highlight. However, as we met with state policymakers, we found that it was often too much information for them to digest. So as a result, in updating the equity profiles, we really wanted to keep in mind that our primary audience is state policymakers, and informed by other work that we are doing around equity and communication, we wanted to make sure that the equity profiles were concise and told a very effective narrative, a story that a policymaker could really follow. And so with that, we have made some updates to the equity profiles, and I'll review those updates with you now. So based on feedback from many of you, we moved the equity profiles away from a dashboard domain focus to a population focus. Metrics in the equity profiles will now be grouped by population, race and ethnicity, disability status, and then there will be an education and income profile versus by dashboard domain grouping to make the gaps in outcomes that populations are experiencing more clear. To be more concise in the metrics displayed and tell a consistent story across population groups, we also prioritize metrics that were available by race and ethnicity, as well as disability status or education income level. So we really prioritize displaying metrics by educational attainment over income level when both breakouts were available, and favored the quality of a measure over the number of metrics. Taking the lead from the National Health Equity Collaborative, we removed metrics around health behaviors to emphasize that not all Ohioans have the same opportunity to make healthy choices and live a healthy life. We want to emphasize that the opportunities a person has are often driven by their social, economic, and physical environment and access to care. You have this as an Excel in your meeting materials, but this provides an overview of the different metrics that we're including in the equity profiles. in the various breakouts for which they are available, we will have two components to the equity profiles. There will be the component that is included in the main dashboard, the laid out dashboard, and then there will also be an Excel appendix. There will be maybe a smaller display of populations. So for example, we're prioritizing education over income and display in the main dashboard. However, we are including all of that data and information in the Excel appendix, equity Excel appendix for the dashboard. And you'll see a little bit more about what this looks like in the 2019 dashboard in just a second. We did identify that there were other components to the equity profiles that we could strengthen. And although we're focusing on race, ethnicity, disability status, and income and education level, there are other populations experiencing gaps in outcomes, such as LGBTQ, immigrants, and so we will have some narrative around the gaps in outcomes that these populations are facing and some of the barriers to getting at data for these particular populations. We will also have some narrative around the need for more disaggregated data. We understand that for some even racial and ethnic groups, the aggregate data can mask disparity. So for example, for the Asian population, we see that they often perform better than other racial and ethnic groups. That is not indicative that there aren't gaps in outcomes across the subgroups within the Asian population, such as Bhutanese or Nepalese refugees. And so being able to just aggregate the data even at a subpopulation level is important. And there are, of course, other barriers to getting at disaggregated data by other factors. And so we'd like to talk a little bit more about that in the equity profile section. And then thirdly, a theme that you'll see in the main dashboard as well, we heard very strongly from you and with other stakeholders that we present the dashboard to and our state policymakers that they want the evidence-based strategies that can help address Ohio's health issues and close Ohio's health gaps. And we will make that a much more prominent feature of the equity profiles as well. You see here a new layout for the equity profiles where we have some narrative at the top and then we display, so this is for Black Ohioans as compared to white Ohioans. We display the metrics from socioeconomic factors that drive health, community conditions that drive health, down to overall health outcomes. And we tell a narrative that you see on the left side of your screen and what that looks like. So Black children in Ohio are nearly 3 times less likely to graduate high school compared to white Ohioans. Lacking a sufficient education makes it more difficult to provide basic needs, such as quality housing. And this has led to large gaps in health outcomes for Black Ohioans. For example, Black infants are dying at 3 times the rate of white infants in Ohio. We'd like to carry this narrative through to the other population groups that we'll be displaying in the dashboard to provide an example to state policymakers and other stakeholders about how the inequities that we see within our socioeconomic environment are impacting our overall health outcomes. All right, and with that, we'd like to open it up to a few more questions and discussion from the group. And the first question is, are there specific components from the dashboard that you think are important to highlight or focus on that we haven't discussed? And then the second question is, how can we strengthen the narrative around health disparities and inequities? And we don't need to go in order. You can provide us with your thoughts. And Amy and I are happy to respond to any questions that you might have on this. And so this is covering, as we've talked about the layout updates, both for the main dashboard and the equity profiles. These questions relate to all of those updates. All right, and let me see here. So Linda, you have a question. Where is the violence by county measure on the dashboard? And we will have, in the equity profiles, we will have homicide rate by county, well, the percent of a population that is living in a high homicide county versus a low homicide county, and that is a metric that we will be including in the equity profile section. And then violent crime rate in the social economic domain of the main profile section will also be included. Steve Wagner says he really appreciates the need for disaggregated data. Will there be mention of the lack of quality race and ethnicity data for health data that is collected, possessed by state agencies? Yes, we will definitely note that. That's that kind of little subsection that we were talking about that will have some narrative around the need for more disaggregated data. We'll touch upon the lack of quality data across race, ethnicity, as well as other populations. Is there a reason that there is no education or training post-high school graduation? I don't know that I completely understand the question. I think maybe Amy will take a stab at responding to this.
If this is a question about educational attainment in general in the dashboard, in the social and economic environment domain, we do have a metric called some college, which is referring to having basically some secondary education beyond high school that could include a 2-year degree, some vocational training or certificate, or a 4-year college degree or more. And so that is aligning with, you might be familiar with education attainment goals, like the state of Ohio has an attainment goal. So that's what that's looking at. If the question is more about the equity analysis, in terms of the breakouts that we look at in the equity profiles, we had to make some difficult decisions about where to have those cutoffs based on the data availability. And so putting that cut point at high school graduation was, given the data that we have and sort of differences across sources, that was the best way that we could capture the most metrics and information on that. Anything to add on that, Zach? Or? Not good. Okay. So hopefully I answered your question.
Any other questions? It looks like you did answer that question, Amy, so that's great job at that. Sorry, I didn't understand. All right, any other questions or hands raised? If we don't see any hands raised, please feel free to use the hand icon if you would like to chime in. And again, the questions are there specific components from the dashboard that you think are important to highlight that we haven't focused on or discussed yet? And then looking at the equity profile section, is there a way that we can strengthen that narrative around health disparities and inequities? Are we moving in the right direction around that? I'd love to hear from our equity advisory group members if they feel like we are moving in the right direction, or if there's something that we could be doing to improve that particular component of the dashboard as well. Carla has a question. Will narrative be included around disparate quality of schools, spending, and need to potentially include some wraparound services in higher poverty districts to achieve equitable outcomes? We did have a metric that we really wanted to include in the equity profile that was around the percent of Ohioans within a particular group, really looking at race and ethnicity that were within a high poverty school. And we were not able to, with the existing data, get to that metric. It is something that we are very interested in exploring more, and maybe it's something that we would be able to add to the next edition of the dashboard. But certainly highlighting how factors, our education and factors within our social economic environment will be at the forefront of the narrative for the equity profiles. Amy and Zach, anything to add to that? No? All right. David Norris looks great, definitely moving in the right direction. I'll email some comments after. Great, David, we'd really, really appreciate that. Any other thoughts or comments or questions? All right. Well, Well, thank you for that feedback. We'll move on to the next portion of our meeting. So I will hand it back to Amy to talk about our focus on evidence-based strategies.
First, we'll take a look at Ohio's top strengths and challenges. This is a section of the dashboard that we often get feedback is quite useful to have a sort of concise list of Ohio's greatest strengths and challenges. This is the strengths page. So these are the metrics where Ohio was in the top quartile. And we have the similar number to what we had last time around. This is from the 2019 edition. This page is under construction, as you can see, and so we would love to hear your suggestions for how to frame strengths or any narrative that might be useful to accompany this. Here we go. This is the challenges page. So on the left is the challenges page from the 2017 dashboard, and then on the right is the preliminary draft for 2019. And we actually had so many metrics in the bottom quartile this time around, more than last time, that we decided to change up the layout so that we could fit everything in one page in a way that would be easier to understand and consume. And so this kind of upstream, downstream flow layout on the right is our idea for doing that. And we would love to get your feedback and thoughts on this framework. And when we present the actionable, concise set of strategies, that we really want to focus in on a few of Ohio's greatest challenges. And so we'd really like your feedback on what to focus on. And this could be a specific metric, or it could be a cluster of related metrics. And again, we'll be keeping these three things in mind. And to narrow down what strategies to include in the dashboard, we're starting with recommendations from other work that we have done over the past few years in partnership with many of you on the call here today. So of course, we have the 2017-2019 State Health Improvement Plan, which is really a menu of evidence-based strategies that address Ohio's highest priorities. Then we have the Social Determinants of Infant Mortality report, which had many recommendations related to housing, transportation, education, and employment with a focus on equity. And the Child Health Assessment, our addiction work, and several other reports. And all of this work has been vetted through feedback with hundreds of stakeholders from around the state and is based on credible sources of evidence. So we're typically working from evidence registries like What Works for Health and Community Guide and others. And we also have a screen for political feasibility. As we envision what we want to include in the next dashboard, some of you might be familiar with CDC's High Five initiative that has a set of specific, more upstream evidence-based strategies, or you may have seen the Trust for America's Health Promoting Health and Cost Control report that came out last week that has this set of 6 goals and a pretty concise list of strategies. So we're envisioning doing something similar in scope to these, perhaps even more concise. So these are just examples of what we're building towards, and we'd love to hear your feedback on if you think that's moving in the right direction. And then these are considerations that we will have in mind as we prioritize strategies. So the focus on equity, looking at which strategies are most likely to reduce disparities and inequities. Of course, the strength of the evidence, and then considering political feasibility and opportunities given our current landscape in Ohio, including thinking about what is the unique contribution for HPIO? What is the unique contribution and potential for leadership that can come from the dashboard that might not be getting a voice or emphasized from other organizations? We'd like to open it up for some more discussion. And our first question here is, which challenges do you think are most important to highlight to state policymakers? And given the current landscape, which challenges do you think there's the greatest political will to address? And then finally, what suggestions do you have for improving our proposed process for selecting strategies to highlight in the dashboard? And again, you can raise your hand or you can type in the question box. And I see we've got a few comments here from Tasleem. She says, love the upstream downstream visual on the bottom quartile. The old one was frightening and rightly so, but less frightening might be more processable and usable by policymakers. Great. We definitely want it to be processable and usable. The frightening, I don't know. That's might be a good thing. How will you rank the intervention's effectiveness? That's a question from Linda. So we ourselves won't be doing the ranking. That's where we look to the existing evidence registries that are out there. So those are organizations. Again, our favorite example is What Works for Health, which comes from the County Health Rankings folks. They are combing through all of the systematic reviews and peer-reviewed journal articles, and then they rate policies and programs based on the strength of evidence of effectiveness on a 5-point scale. And so we will rely on that. We will rely, there are many other sources as well in terms of thinking about the social and economic environment. We look to sources like Top Tier Evidence and the Results First initiative from the Pew Foundation and many other sources where they have done that rigorous work of reviewing all of the research evidence. Okay, and then from Terry, I think the CDC High Five link to goals for Ohio is a great approach to demonstrating cost-effective interventions. And that's a great point. High Five does have one of the criteria is that they are highlighting strategies that have some evidence of cost effectiveness, cost savings within a 5-year time horizon. And so that is a really helpful one to refer to. Some thoughts on the questions. Let's see, do we have any hands? Okay. Linda, if you want to add to that, you could raise your hand. And don't think I'm seeing. Oh, here we go. All right. Linda, take it away.
So I started to type it out. I think there's a need to highlight the community interventions, the recognition in this state of how important it is to encourage community level interventions. The second is, and third, well, the second is it's clear that children and recovery from addiction are big issues for this administration, and I think that it would be good to play to those, because I think that's where there's some political will. And the third thing is, I think for selecting the highlights, we really need to focus on what questions are people getting from legislatures.
Mm-hmm. All right, great. Thank you. Great considerations for how we select what to emphasize in the dashboard and also some of that context and narrative. Thank you. I don't see any other hands up. All right, I'll take us, whoops, maybe we do have a hand up. Okay. All right, oh, I do see a question in the chat box here from Srinivas. While most folks involved in healthcare have recognized social determinants of health as vital, it is still important and necessary to highlight those factors and thus potential budget priorities for state policymakers. Yeah, great suggestion. We'll definitely be looking at upstream policies and programs to highlight. And now I'm going to turn it back over to Reem.
Thanks, Amy. You all are such a terrific group and have wonderful feedback and insight for us to really consider as we are moving forward. We do want to make sure that the dashboard per your suggestions is a tool that can help to focus the work versus boil the ocean. And we want to make sure that we continue to simplify the path between the metrics and the policy changes and strategies that we emphasize in the dashboard. We really appreciate all of the feedback that you have provided. We will be using that to help us in deciding what to include in the narrative. Of course, our focus with the dashboard is always to make sure that it is concise and easy to use for state policymakers. So there are limitations on what we can include and how much narrative we can provide, but your suggestions have been very helpful in providing us with some parameters around what we should really focus on. We wanted to transition a little bit to talk about dissemination of the dashboard and are posing just two final questions for you. And I really want to focus on that number 2. So the first is, are there other components that would be useful for communicating to policymakers that we could incorporate? Understanding that we are at the layout stage now, and so we're not able to do extra data compilation analysis, but if you can think of other things that might be easy for us to implement and useful for communicating to our state policymakers or other stakeholders, we'd love to hear that feedback. And then that number 2 is, what ideas do you have for how you all can contribute to dashboard dissemination? We know that the dashboard on its own is not going to change policies in the state. It really is, we rely on all of you to help us in our dissemination efforts and to also use the dashboard data to tell stories regarding what the data means or what can be done to address issues or what you're working on at a local level or within your communities or even at a state level. And so we wanted to generate some ideas about how advisory group members could contribute to dashboard dissemination. And we got lots of comments here. So I'm going to see if I can. All right. Steve, I appreciate the comment on having cost-effective strategies. These may be politically feasible. I don't think we should lose sight of cost benefit. I don't know where EITC comes in as cost-effective, but it has significant benefit for those working in poverty. Steve, we would agree with that. EITC has been shown to be a very effective evidence-based strategy, can really help to eliminate and address child poverty in particular, and has a number of health impacts. And that is a strategy that we have highlighted in previous publications. We'll also be taking the pulse of the legislature and the administration to see what it looks like as far as political feasibility. So we'll want to balance both evidence-based. We know that it has an impact with political feasibility when we're highlighting strategies. So I really appreciate you bringing that strategy up. Linda Post, one other thing that may be important, clarifying things like what percentage of pregnancies are covered by Medicaid, what percentage of state Ohioans who are with a disability are on Medicaid, what percentage of Medicare members get Medicaid. Again, this is providing more context around Medicaid. And we might not be able to fit all of that information in the dashboard, but we will link to that information when possible. We will also be doing, as Amy mentioned, a series of follow-ups to the dashboard. We have a Medicaid Basics publication that we plan to release in the next few months, and so that data and information may be included there. Linda, you also have a suggestion to put the strengths and weaknesses, so strengths and challenges first, along with some potential interventions. And I think that's something that we definitely agree to here, is that we want to highlight those, and we want that to be at the forefront or at the face of the dashboard. So we are thinking about how to strategically place those pieces or components of the dashboard. Steve, you said a good one-pager on, oop, I lost it. Okay, a good one-pager on health disparity and health equity. I do not think that there is a good understanding. Yes, so we have done previous one specific publication around closing Ohio's health gaps that we can pull some narrative from, but part of the reason why we're restructuring the equity profiles is because our feeling is that many state policymakers do not have a good understanding of health disparities and how inequities drive those disparities and other historical and contemporary obstacles and challenges that these populations face, and we're really trying to make that more clear in these equity profiles. So a one-pager might be helpful in doing that. We are planning to have I can't promise one-pager, because at HPIO we struggle with one-pagers, but maybe like back and front two-pager on the strategies that can be implemented to address gaps in outcomes. So we do want to do, and we are planning to do, a specific publication on that, or brief on that, a short one in later on this year. And that may be another opportunity to weave that narrative in, or that explanation in. Linda, a great suggestion about how advisory group members can contribute to the dashboard, and that's sharing the dashboard with their organizations and legislators. That would be excellent. We very much encourage you to disseminate and share the dashboard as widely as possible, and tie it into your work as you see alignment, and that can really help elevate and strengthen the dissemination and messaging that comes with the dashboard. Kelly Hogan, there is an important link between educational attainment and workforce opportunity. Are you thinking about how to work into the equity narrative, how health lives are impacted for those who work in multiple jobs that keep them in poverty range? Race will show disproportionate numbers if disaggregated. We are thinking through how to best communicate that narrative. What we see is really the largest gaps in outcomes for income and education level. We also know that disproportionately impacts Black Ohioans, and so how to really weave that story together is something that we're still contemplating. So really good point here. I'm gonna pass the mic to Amy to answer a few questions, and open up to you all for discussion and dialogue as well. So if you have any questions, please make sure that you use the hand icon. I know that I'm reading from the chat box, but sometimes you all might have more to say than what's in the chat box, and we'd love to hear your thoughts on that. So I'm going to pass the mic now to Amy.
Thanks. And one other follow-up on that question or suggestion from Kelly. We did write a whole brief on that topic, what works for self-sufficient employment. And so at the very least, we can link to the information in that, but we do already have some material that addresses that can be woven into the dashboard as well, particularly as we look at that social and economic environment domain, where we certainly have some struggles relative to other states. And then from Terry Allen, we have, as issues are being debated in the legislature in the budget process, consider releasing at-a-glance type reports that extract relevant data from the dashboard related to the issue of the moment. Great suggestion to make sure the dashboard is as relevant as possible to the state budget process. That is the reason why we release the dashboard every 2 years, to align with the budget cycle. So we'll definitely be staying on top of that. And I'm not seeing other questions in the chat box. I will scan for any raised hands. Not seeing any. Do we have any final poll questions or anything? Okay. All right, I'm going to turn it back to Reem.
Thank you all again. You, as I said, are such a terrific group of stakeholders. We are very privileged to have the opportunity to work with all of you and appreciate your dedication to this work. And so many of you have been involved in the dashboard and other advisory groups that we convene. We just so appreciate all of the feedback that you provide. It really does help to enhance the quality of the work that we do, and certainly gives us hope that as Ohio we can perform better on health value, because we have so many committed stakeholders that really are dedicated to the issues that we see rising to the top in the dashboard as our challenges. As far as next steps, we are planning to have a series of 3 dashboard release forums. The first will take place in Columbus on April 4th, the second in Cincinnati on April 17th, and then the third in North Canton on April 30th. The registration link for all 3 of these dashboard release forums is live, and so you are able to register if you have not already. These 3 forums will each have similar agendas, and so they're not going to be different overall agendas. We will have different speakers at each of these forums, but covering the same topics. So we wanted to make sure that our stakeholders that are living in other parts of the state had the opportunity to participate in the dashboard release forum as well. We love to see you all in the audience. You are our strongest really advocates for this work, and appreciate again your investment and commitment to this. As always, please feel free to reach out to myself or Amy Bush-Stevens with any questions that you might have, and any follow-up comments or suggestions that you may have. We will be working tirelessly to get the 2019 dashboard ready for release between now and the beginning of April, and we may follow up with a few of you on some of your comments and feedback as well. So we'll circle back as we need to. I want to just make sure that nobody has any final comments or questions. We do have, it looks like, a few more. All right, I'm just maneuvering to see. All right. Valerie Aloy, even one well-written paragraph describing how historical policy across institutions has resulted in less and harder access to resource by minority and other populations. I think the sentiment there is that would be helpful. And Valerie, we agree, and so we will do our best to convey that in the equity profile section. And Krista, and that is something that we have begun to incorporate in that narrative, that gray narrative at the top of the equity profile for Black Ohioans. So would love your feedback on that, and if that's kind of what you had in mind. Krista Stock, you're going to end the meeting with great job, HPIO team looks great. So we did not plan that, but I think is a good stopping point. Please, again, feel free to reach out to myself or Amy Bush-Stevens if we have if there are any other questions. We do have a poll question for you, one last final one, which is, which dashboard release forum are you planning to attend? Get your commitment now. There's no backing out. Yes, this is not a reservation for the forum. You will still need to register even if you take this poll. All right, it looks like we've got good response. We'll just wait a few more seconds, give everybody the opportunity to respond. All right, let's share our results. I can't see the results. Let's see, one second. Okay, looks like most of you are going to be joining us in Columbus, and about a third in Cincinnati, and then some in North Canton as well. That's great. We love to see that. And for those that can't attend, yes, please do encourage others to attend the forum. We would love to see you there. And we are happy to provide flyers to you if you'd like to distribute. We'll follow up with a flyer to all of you that you can distribute to your organizations and your colleagues and other stakeholders as you see fit. Again, the webinar is recorded, and we will post the webinar after this meeting for those that couldn't attend or want to just go back and listen to one portion of today's meeting. Thank you again, and have a wonderful, wonderful day.